Hello everyone, good evening, good morning or good night. Glaucoma management. In the part 1 we looked at a whole lot of things, so just in case you've not subscribed, please make sure you subscribe, like and share this assessment. We want to look at the non-specific signs we will see when we are examining a patient in a clinical setting. Collaterals between two veins at the disc, loss of nasal neuroretinal rim, lamina is disc hemorrhage. So disc hemorrhage is very important in the sense that it's signs we see when it is a risk factor for the development and progression of glaucoma. What we are trying to say is that every time we see a disc hemorrhage in a disc, we want to question why is it there and then probe further. Developing glaucoma with disc hemorrhage, it is likely disc hemorrhage, but likely going to miss the presence of a disc hemorrhage. Also, it extends from systemic vascular diseases, so it could be an ocular diseases, so it could be an ocular manifestation of a systemic vascular disease. Can also be seen in head border, and be careful. It is important that a fundus photograph is taken once the hemorrhage is noticed, because they can disappear after a disc hemorrhage look like. You can see this is the disc and you see the hemorrhage somewhere here. Now this is a magnified image. It might not always be the presence of a disc hemorrhage. Another sign we are going to look at is barring the neuroretinal rim and superficial blood vessels. It has a low specificity, hence not entirely specific to glaucoma. Vital tool that indicates the presence of glaucoma, but yet every time we see it, we want to question why it is there. And the presence of a circumlinear barring, you can see this vessel here. It appears as though it has lost its structural support. Important when we see it in glaucoma, we want to question retinal rim loss is present through the disc. It went back, and then you can bayoneting, and it is highly indicative of glaucoma. So you see also in this image there's a thinning of the neuroretinal rim. You can see the loss in neuroretinal rim here, and the cup-to-lid ratio of this patient is about 0.7 to 0.9. Also, loss results in shifting of the central retina in the neuroretinal rim accompanied with bayoneting. Remember, we said that in a healthy patient, the neuroretinal rim should be managed. This is the easing through. But when we begin to see a loss in neuroretinal rim, especially this loss in tissue and the shifting of the central retinal veins, question further. Structure. It provides nutritive support for its axons and acts as a pressure barrier. So the lamina cribosa is a structure in the optic nerve head. Apart from providing visible, we want to question why it is nerve damage and there's a visual field loss going on. But nerve damage and there's a visual field loss going on. But then our CVF results will give us a better view of what is going on. And a wound the patient maybe 2 years ago, we were not seeing the lamina cribosa so evident. 2 years ago, we were not seeing the lamina cribosa so evident, and then we are seeing it evident now. It tells us a whole lot of fenestrations here. This is what we call the lamina cribosa, and you see that it is so evident. So it is a cause for alarm. Barring of circumlinear blood vessels present. So all these are some of the things we see in a class. Fenestrations. These are what we call lamina dot fenestrations. These are what we call lamina dot signs. The next on my list here is peripapillary atrophy. This is usually seen as a black patch around the optic nerve head, the alpha zone, both in a patient who has glaucoma and patients who do not have glaucoma. It is present, but then also the darker area is called the alpha zone. But let's look at the next slide, and then it gives us a key. On what to likely visual field loss. So wherever we see this beta zone, it tells us likely there is a visual field loss in that area. do not have glaucoma, I can also see there is a visual field loss in that area. Do not have glaucoma, I can also see it in glaucomatous eye, but the beta zone is more specific for glaucomatous eye, or the peripapillary atrophy eye, or the peripapillary atrophy, and then this is the alpha zone, while the inner segment is the beta zone. So when we let's look at the retinal nerve fiber layer. Glaucoma causes damage to the retinal nerve fiber layer, and ophthalmos damage to the retinal nerve fiber layer, and ophthalmos. These striations seen respect the horizontal raphe, and it is easily observed in the temporal periphery. So when we anatomy of how the retinal nerve fiber layers, how they come into the optic nerve head, you find out that they act around the macula, and that when you use your green filter, you will see fine white linear striations. These are what we call damage. RNFL loss could be diffuse or localized. It could be diffuse in the sense that it is everywhere, or it could be localized. It just that it's under a green filter with your ophthalmoscope. And a look to say. Now look at this image. Nerve fiber here. So this is how disc. So do you see it here also? Disc. So do you see it here also? And then the papillomacular bundles are somewhere here. So this is the superior. So this is the superior arcuate fiber, and this is the inferior arcuate fiber, and this is the inferior arcuate fiber. See a dark band arcuate fiber. See a dark band, and you can also this dark band here. It is band, and you can also this dark band here. It is more. The loss is more in also this dark band here. The loss is more in the inferior aspect. Remember we said that glaucoma damage the inferior aspect. Remember we said that glaucoma damage, we can see that the band here is greater than the one superiorly. Now this is an image of an eye, white striation of and it's defined as a dark wedge-shaped area. It was for this image is trying. So what is the summary? The summary of the 5R summary simply is that. So what is the summary? The summary of the 5R summary simply is that you observe the miss of the optic disc and size. Want to quickly at glaucoma, the retinal nerve fiber layer. Remember that in a large cupping and neuropathies, I've seen a large cupping and neuropathies. 0.8 or 0.7 focus to other forms of neuropathy that can lead to cupping. Also want to examine the region of the peripapillary atrophy. We said that the matos. I also finally want to examine the retina and the optic disc for hemorrhages. Remember, we see the end of the class for today. Next week Saturday we will look into another subject. Next week Saturday we'll be looking at optic comment, and do well to like the video.